Good morning. Okay, well, it's been quite a while since I've actually had to record a lecture. So, this is updated information from the 8th edition of the Patient Care Book. This is chapter 25, which is Health Informatics and Information Management. Now, I will tell you ahead of time that some of the content comes from older editions, but it actually is extremely important to know. So when that happens, I give you a heads up first so that you're not trying to look through the book and figure out where I am. This chapter begins on page 348. Again, it's chapter 25. All right. When they start off in this chapter, they start off talking about health information management, and that is abbreviated HIM. You'll find a lot of abbreviations throughout this chapter that realistically in radiology, we do tend to use a lot of abbreviations, and I know sometimes that can be frustrating, but it's important to make a list of those or at least try to commit those to memory because you definitely will be seeing them once you go out on clinicals as a student and definitely in field as a technologist. So this chapter is basically about the health record, a patient's chart, and it used to be in paper format. Some facilities do still have paper format. Most have moved to an electronic health record. So what really does this record contain? Typically what happens is anyone that provides service to a patient from a healthcare standpoint, regardless of where they are, will have to maintain all that information on that patient, and they have to maintain it for a certain time frame depending on what the information is. But the purpose of it is to actually concentrate in one record all the information about that patient so that there is effective communication among departments, there's continuity of care. Basically what happens is anytime you go to, say, hospital A, anything that's done to you in hospital A, any service that's provided by any department, that information has to be maintained in that record. Like I said, for a given time frame, and we're talking typically years that has to be maintained, so that if you end up coming back, they have record of you. If you end up needing that information for another physician, maybe you've been referred, they can get that information. It just, like I said, provides continuity of care, and they are a service-oriented department. A lot of times with that department, different things that they function for, they have to support the current and continuing care of a patient, meaning pretty much without this department, without medical records or health information services, without those personnel, nobody in a facility, I do tend to say hospital, but regardless of if it's a hospital, outpatient center, surgery center, whatever it is, without this record, most of us are not going to be able to function because we're not going to be able to get the materials needed in order to know what results we've got on the patient, what the orders actually were, and to be able to see previous things. So they support the care of the patient. Their job is basically to maintain that health record. It supports the institution's administrative processes. A lot of times we don't tend to think about that. There's all kinds of processes outside just caring for the patient. A lot of times, like during COVID, all the stats came from the health information that was recorded in patients' charts. That's how they publish the numbers, or they talk about the numbers of current cases. There's statistics that are recorded through this. So there's a lot of administrative process and process outside just the patient and the provider. They have to maintain these records for billing and accounting processes. A lot of your clinical decision making and your financial reimbursement comes from the information that is in that health record. So they do mention that, if there's an error recording an medication that's given to a patient, that could lead to a life-threatening event happening to the patient, which that's typically what we think about because we provide patient care. But on the administrative side, if there's an error in data reporting, that could be not only harm to the patient, but there could be sizable financial loss for the healthcare institution. And regardless of how you or I feel about the fact that the hospital is a business, it is, and it has to function to make money. If they don't make money, then they can't pay their employees, which means somebody is, or multiple somebodies are out of a job. So it definitely is important that all of this information be recorded properly, maintained properly, and accessible to anyone that has access, that's allowed to have access to that. That is important. And they also support medical educational programs. They also have to ensure patient privacy and security issues. That's a huge thing, especially since these are electronic records. We'll talk a little bit later about HIPAA and the importance of that. That is probably one thing that I cannot stress enough, is that you protect patient health information. They maintain the records for utilization management, risk management, quality management, performance improvement, like a lot of different departments that don't have direct patient care or direct patient contact. They use those records to improve performance in a facility, or to analyze the risks that are involved with the way the current practices are. There's just a lot that goes on. It helps, health records help to support research. And basically, like I said, during COVID, any research that comes about, they can go back to facilities and gather information. Facilities can choose to take part in sharing that information. Usually, if it is a government funded institution, then they automatically have access to that information, meaning that they're allowed to gain information for either statistics or education or research purposes. I know I keep saying a lot. I apologize for that. I know it's annoying. They also have to ensure, this department has to ensure that they comply with any legal requirements, because there are different organizations that require that they comply, like the Joint Commission. It used to be called the Joint Commission on Accreditation of Healthcare Organizations. A lot of times you'll still hear people refer to it as that, but the Joint Commission states that you have to have your health record in a certain, not necessarily a certain format. There has to be certain information that is accessible. The format you put it in really is up to each individual facility, but there are regulating agencies that define what can and cannot be done. So it used to be that anybody could work in what we called medical records, but now a lot of those departments actually require people that have gone through schooling, their degree holding in that particular area. So a lot of the degrees that you'll see are health information management, health information services. You can actually get a degree in those areas. The electronic health record, or EHR, there's one of your abbreviations for us. This literally has changed how health information is managed. It used to be a paper chart or charts, because depending on how many times a patient was at a facility, they might outgrow one paper chart. So they could have 2, 3, 4 paper charts, and those would all have to be maintained somewhere where they were accessible. That limited space, it caused the need to rent like warehouses and extra storage space to maintain these records. But with electronic health records, you can store a lot more information electronically. You can back it up. You can access it far easier than trying to send someone to go find the chart from the patient that was there 8 years ago. So it's definitely improved, but a lot of things have changed with the electronic health records, and people being able to get access to that, whether legally or illegally, also comes into play. So that electronic health record includes information like patient demographics, meaning patient information, who they are, where they live, how old they are, things like that. Any progress notes that are made about the patient, any problems, any medications the patient might be on or has been prescribed or will be prescribed, their vital signs, their past medical history, typically their past medical history, their reason for coming to this point, maybe something in the past kind of relates to that. Any immunizations they currently have or maybe do not have might be valid. Any laboratory data and radiology data is also recorded in there. And I realize I only mentioned those two departments, but realize respiratory therapy, occupational therapy, physical therapy, they would all have information in that electronic health record as well. So it basically should be a complete clinical compilation of all the departments that treated that patient at any given time, and as long as that patient is still within the time frame of needing to be that record to be maintained, it would have to be. I'll give you an example. When I'm talking about that, let's talk about x-rays, for instance. In radiology, if you take x-rays on a patient, let's say that you took them January 1st, 2024, you would have to maintain those x-rays, reports, everything about that patient, assuming that was the first time they'd ever been to your facility, say they never came back again. Everything that happened to that patient would have to be maintained for a minimum of 7 years beyond the last date of service. So if you were seen January 1st, 2024, then you could not get rid of those records until January 2nd, 2033. So imagine when those were paper, how much space that would have taken up, how much space the films took up. Because again, just like records are electronic, now our images are stored electronically as well. So we don't have that space issue that we ran into with having to store films, having to keep it climate controlled and all of those kinds of things. So kind of crazy when we think about how far we've come with that. Now, this is not in the book, but it is important information. According to the Joint Commission and the Healthcare Facilities Accreditation Programs, a medical record has to contain sufficient information to identify the patient, support the diagnosis, justify what treatment was done. It has to document the course and the results of that and promote the continuity of care among healthcare providers. Okay, so that's kind of a sum up of why is a medical record so important. And according to Medicare, the medical record has to contain information to justify the admission and continued hospitalization, support the diagnosis, and describe the patient's progress and response to the medication and services. So Medicare plays a huge part in what is and is not allowed by other insurance providers. So those are just a little tidbit that I wanted to pass along that is important, even though we don't necessarily tend to think about those kinds of things. You do once you're in field, but as a student, it's just interesting to see that Medicare plays such a huge part. All right, the Master Patient Index, or the MPI, that is an electronic file that identifies all patients that have been either admitted or treated at a facility. Okay. Every patient that gets registered to receive care, whether they're an inpatient, an outpatient, an emergency room patient, anything at all, referral, home care, any care that's provided by the facility, have to be listed individually in that Master Patient Index. They talk about that Master Patient Index is probably the most important thing that a facility can maintain. And there's two levels that have to be, information has to be recorded in that Master Patient Index. So there's the demographic level and there's the visit level. And these bulleted points are on page 349 for you. But when they talk about the demographic level, like the demographics of the patient, so it's specific to the patient. So it has to have a medical record number. That's probably the biggest thing, that master patient index has to list the patient and their medical record number. It has to have their legal name, including any surname, their given name, a middle name or initial, any suffixes, any prefixes specific to that patient. It has to have their date of birth, their gender, their race, their ethnicity, their address, their telephone number, their alias or previous or maiden names, a social security number, a facility identification, meaning where they're being treated or taken care of, and then a universal patient identifier if it is established. Now, it's interesting because I believe one of the questions in the back talks about what don't you have to have in the health record. And I believe if it's still in there, the answer is a phone number. So I don't know that it's necessarily required, but if a patient has a phone number, which now pretty much with cell phones the way they are, most people don't have house phones, but they definitely have access to or own a cell phone. So that's all the demographic information. On the visit level, there has to be an account number or a visit number, an admission date or an encounter date, a discharge date, the type or of service that was provided or encounter, the location of that service or that encounter, the primary physician that was involved, and the patient disposition. So all of those things are necessary in the master patient index. Then we have the history and physical component. Okay, this basically tells someone why that patient is being seen, either for their current episode of care, their history, their physical. This is specifically in order to gather a complete history and physical that are required by licensing agencies, accreditation agencies, and more importantly, for reimbursement purposes. So what does it include? Now, this is on page 350 in the chart, the purple chart. So it has to have the chief complaint. Now, that is a statement made by the patient that basically defines why they sought treatment. What is going on that brought you in today? And it's not a diagnosis. It literally is whatever the patient says for why they went to be seen. I came to be seen because my stomach is killing me and I've been throwing up for 3 days. That would be a chief complaint. Okay. I fell down and I can't move my arm. That's their chief complaint. And they reference that with an abbreviation of CC. Then they talk about their history of their present illness, or their HPI. So the history of the present illness gives a time frame to what is going on with that patient. If they've got abdominal pain and vomiting, you would have to, or somebody would have to log, when did it start? What kind of symptoms did you feel when it came on? Maybe they were nauseous for a few hours and they tried to remedy that, and it just continued to get worse. And that brought about their vomiting. And then they've been continuing to vomit. They're not really keeping anything down. And now their stomach pain has come on. That would be the history of their present illness. Also included in the history and physical is a ROS, or the review of their symptoms. So it's a systematic inventory of all the body systems reported by the patient that helps the physician or the clinician to identify other symptoms that might be going on. In the book, they tell you the patient might deny vomiting, diarrhea, a rash, and no other findings noted by the patient. So basically, what by body system, what do you have going on? Let's review your other symptoms. Maybe there's something else that goes along with that. Past medical history, any past illnesses, surgeries, pregnancies, allergies, and typically will include current medications that the patient is on. It has to include their family history, their social history, a physical examination performed by a clinician, typically that will include vital signs, anything else that anything that the physician noted, whether it was a, oh my goodness, I'm blanking out, whether it was a subjective information, meaning only the patient could provide that, or it was objective, meaning the clinician was able to visibly see it and use one of their senses, whether you see it, smell it, hear it, feel it, things like that. But that would be the clinician is doing that. So that would be included in the physical exam. And then another or last thing that's in that history and physical would be the impression or the diagnosis with a treatment plan. So once the symptoms are all listed and all the information is gathered, then the clinician, the hospitalist, the physician has to come up with what is the impression that I'm getting from this, or what is the possible diagnosis, and what are we going to do? What tests are going to be ordered in order to confirm or deny this? All right, ancillary reports. Ancillary reports, basically you have to have documentation of every order that was generated. Like if it's an x-ray that was ordered, there has to be an x-ray report included in that. If they ordered respiratory, there has to be a report of that respiratory interaction. So all imaging studies, any lab work that was done, any pathology reports, any time that the patient was monitored or they were tracing some kind of body function, if they were monitoring urine output, any of that, then those ancillary reports are also going to become part of that patient's health record. All right. I'm going to talk about something a little bit later, again, not necessarily in the book, but it has to do with the ancillary reports that make it on the electronic health record. But another thing that would be in that EHR would be an op report or an operative report. This is anytime the patient has surgery. It is going to include things like who were the surgeons and the assistants in the room. So if we were in during the case, we would be listed in that op report. The anesthesiologist would be in there, the scrub tech, anybody that was in that room. Even if they didn't stay, but they came in, did something and left, it has to be recorded. Their pre-op diagnosis has to be listed, and their post-op diagnosis has to be listed. The procedure has to be explained as to what was done to the patient, the anesthesia that was given to the patient, very specifically, all of these things. It's not just, one line on that. Everybody has to report that information in the op report, a description of the procedure. When they talk about this too, like if we're involved, you would have to document what images were taken, the amount of fluoro time that was utilized in the room. All of that information has to be documented in an op report. All right. This is the part that I was telling you that is not in the book, but it is specific to our radiology records, just so you're aware of it. So before we can ever do any kind of radiologic procedure, there has to be an order or a request for service, meaning typically, unless it's a trauma situation, you have to have some kind of written or documented, like on the computer, there can be the order, it can be a written order, it can be an electronic order, but there has to be some type of order generated before we can complete service. It cannot be a verbal order unless you're in the trauma room. Why I say that is if it's life or death and the doctor is telling you, get me a chest, get me a pelvis, I need that now. We're not going to tell them, oh, sorry, I need a written order first. What's going to happen is somebody is recording everything that's going on in that trauma room, and all the orders will follow once the patient is cared for. So once that's done, we would get the order. Other than that, we have to either take it off the computer, or if a patient brings in an order, it could be something like that. If the order is not correct, we cannot do the exam until the order is corrected. Okay. So it's very important that you have proper proper requisition before you do anything to that patient, because remember, you're doling out radiation, so you have to have an order that verifies and justifies that. On that order, there must be either a diagnosis or a sign or a symptom for why they're ordering that test. And not only does there have to be a diagnosis or a sign or symptom, it has to correlate to what exam is being done. So if you have an order for a patient's tib fib, their lower leg, and they want images of the tib fib, and the reason for exam says abdomen pain, that doesn't justify ordering a lower leg extremity image with abdomen pain. So whatever that diagnosis or sign or symptom is, it has to correlate to the exam that's being ordered. Once that exam is performed, there has to be results of the procedure. So this is where the report comes in. And that should be in the patient's electronic medical record as soon as possible after that procedure is completed. Typically, I would tell you, if it's an outpatient type deal, it's probably on there within 24 to 48 hours. Sometimes they can order exams stat or immediately, and those they would get a preliminary report immediately, and then a written report would follow shortly after. It just kind of depends on the facility and the urgency of the exam, but most reports are on the chart within 24 to 48 hours. Along with that, any special reports that document the evaluation or treatment of a patient have to be made as part of the patient's permanent record, whether it's electronic or paper, it wouldn't matter. I'm sure you can hear the cuckoo clock, so for that, I apologize. All right, the radiology reports are provided by a radiologist, meaning that is who will read the images and dictate a report. The patient's images are typically kept in the department PACS system. We'll talk about PACS later. That's the place where we store those images. The report is also typically maintained in the radiology electronic health records. So we tend to have the images and a copy of the report. That report has to be signed by the interpreting radiologist. Now, back in the day, it used to be like an actual signature. Now it is an electronic signature, which means that radiologist has to read through and make sure that what he or she said is what is in that report, that there's nothing, no errors, no misinformation. And once they've authorized that, then they have an electronic signature on file, and they can click a button or click the mouse, and it electronically signs that they agree to and abide by and back everything that was in that report. Typically, the reports are transcribed, meaning someone is listening to the dictation and it is being typed out as they are reporting on that information. A lot of times it's voice activated, meaning if I'm talking, then it's recording and it's being transcribed. But when I stop, it's almost like talk to text. When they talk, it starts to type it out. If they stop, it stops. So kind of interesting, but just like talk to text can give you some errors when you read it back, so can these reports. So they have to read them back, because basically they are liable for everything that's in that report, and anything that goes out that is incorrect, they can be held accountable, which usually means some type of lawsuit or something of that nature is usually what it means. All right, now back to the book. This is on page 351, where they talk about physician's orders. So any treatment, any procedure, any medication that a physician wants a patient to have, there has to be a physician's order on that medical record, or in that medical record. Okay, so it has to list the test to be performed, or the procedure to be performed, or the medication that they want administered. Along with that, there has to be a diagnosis or a sign or a symptom. all of this goes to the reimbursement, meaning a physician just can't randomly order something with no basis for it. So there has to be medical necessity involved when they do that. And that's the reason why you need either a diagnosis or a sign or a symptom, because you might not have a diagnosis at that point, but something is going on with the patient. They have some kind of sign or symptom that would indicate this is needed in order to confirm or deny that's what's going on. All right, the patient portal. I'm sure everybody has at some point, either you have your own patient portal or you have a family member that has a patient portal, but most of your hospitals tend to have portals. Advent Health definitely has a portal. There are some smaller imaging centers that have patient portals. Mayo has a portal. I mean, it really is ingenious that we have these patient portals. It allows the patient to take part in and review things that were done to them or for them. So it really is a huge part. It gives them access to their medical record basically 24 hours a day. They can access it. Now, what they can access is kind of determined by the facility, but a lot of times you can pull up your images on there. You can pull up your radiology reports, your lab results, what the doctor said to you. Like if you forget, oh, I can't remember what they wanted me to do, you can go in. You can usually read like after visit summaries, things like that. I mean, they just have amazing information on there, which is really helpful. I think for the patients, because a lot of times when you're in there and you're listening and you're trying to follow, sometimes you're just overwhelmed and it's a lot of information. A lot of your elderly patients tend to struggle with this as well. So what are some things you might find on the portal? All of these little kind of bulleted points on here. So a summary of the visit, any medications that you're on or they prescribed, your immunizations can be on there, your allergies, your test results, the physician's notes, any messaging. A lot of time you can message back and forth to the provider, or the provider can message you and you can answer, which is so helpful, especially when leaving voice messages or calling and leaving a message. Sometimes that gets overlooked, but on the portal, literally somebody's job is to sit there and monitor the messages that come through and make sure that they are answered in a timely manner, which usually when you message on there, they'll tell you that you'll have a response within 24 business hours, I believe is what it says. So it depends on where you're messaging. Prescription refill requests are on there. You can schedule sometimes from your portal. You can verify benefits from your portal sometimes. The patient demographics, meaning your name, your information. I mean, it has so much information about you on there, and you can access that. It typically has like how many times you've been to that facility. All those visits are listed in there, your vital signs from that, your height, your weight, all kinds of information. You can make payments from it if you have a copay that maybe you didn't pay while you were there, or you told them to go ahead and bill you. You can go on there a lot of times and they can have a link where you can pay. Sometimes they have educational information about what you might be experiencing, like maybe you had elevated blood pressure when you went, and they would have access to an article maybe on hypertension or dietary guidelines for borderline hypertension, or exercises that can lower hypertension, things like that. And a lot of times you'll have form completion on there where you can kind of register and do everything you have to do when you get there. You can do ahead of time from the privacy of your own home. And then basically you can fill out the forms and pay and walk in, and they literally check in and you're good to go and be seen. So a lot of information on that patient portal. It really is a nice thing for patients to have. But along with that nice access to your information 24 hours a day, there also is the potential that others could access that information. So we're going to talk just a little bit right now and more later about HIPAA. HIPAA is the Health Insurance Portability and Accountability Act. It came about in 1996. And basically what HIPAA does is it makes sure that patients have a right to access their personal information. Okay. So patients do have a right to their own personal health information. They do mention, I'm going to go back to the Century Cures Act, but with the patient portal, this is what I kind of wanted to make sure you see. With the patient portals, it facilitates the patient's involvement in their own healthcare. When they have access to that portal, they have a vested part in their actual treatment. So it should be a secure online website that allows the patient 24-hour access to their personal health information and their medical records. It's just they can access all of that stuff that we talked about, but it is protected, because if that was ever breached, it would mean that all of your information would be out there, which would be a huge HIPAA violation for sure. All right, so we'll go back to HIPAA and we'll talk about that stuff in just a minute. But the revenue cycle management that they talk about, okay? Revenue, basically, like I said before, most of these places are businesses. All of them are businesses. But I'll be honest with you, a lot of times I'm focused on the patient care. Not that I knock the fact that they're a business, but my mind doesn't always think about the business, the financial side of it. My mind tends to think about the patient and caring for the patient. But somebody's got to pay attention to the financial side, or the facility would no longer exist, which would mean I would not have a job. So when they talk about the revenue cycle, there's 3 areas that they mention are important. And these are in that figure 25.1 in the textbook on page 351. They talk about there's a front end, a middle end, and a back end process. So the front end, they tell you, is the patient access, scheduling, pre-authorization, insurance verification, point of service collection, and financial counseling. The middle process is where the charges are implemented, and there's clinical documentation and coding to support what was done. And then the back end is where you actually process the claim, payment posting, any follow-up collections, and denial management. So that those are your 3 processes for the revenue cycle. And they reference heavily about medical necessity. And I mentioned that before. According to the book, by definition, it's healthcare services or supplies that are needed in order to diagnose or treat an illness, an injury, a condition, a disease, or its symptoms, and that meet accepted standards of medicine. Okay, and that actually came from Medicare.org. So when a physician or someone that's allowed to orders a diagnostic exam, there has to be a diagnosis, a sign, or a symptom that justifies that being done. Like we said, not only does it have to be there, but it has to correlate to what's going on. When they talk about the ICD-10 and the CPT codes, those basically, I tried to simplify it for you. The coding process is part of that middle portion of the revenue cycle. So the coding mechanism, like we said, has to have a diagnosis, a sign, or a symptom. It also has to have their reason for their visit. So the CPT codes, okay, it stands for Current Procedural Terminology, and it's the 4th edition. Those are the codes they're currently using. So the CPT codes actually is a code for the procedure that you're doing. And those numbers, 70010 to 79999, all of those are diagnostic and therapeutic numbers that correlate to either radiology, nuclear medicine, ultrasonography, and radiation oncology. And they give you some examples that, like 71045, that number means that the patient had a single view of the chest. If it was the CPT code was 71046, then it means the patient had a 2-view chest. All right. So do you have to know all the CPT codes? No, absolutely not. I remember one of my first jobs, we had to code all our own exams, but we had a little cheat sheet that the most common ones were listed on there. We would have to write the code, and then we would also have to give the ICD. Back when, back then it was the ICD-9 code. Now they are ICD-10 codes, and the ICD stands for International Classification of Diseases, the 10th edition. Okay, so the ICD-10 codes, they actually code the diagnosis, the sign, or the symptom that provides the medical necessity. So with those, they give you an example that, like if a patient complained of a cough and shortness of breath, then the ICD-10 codes would be R05 is cough, and R06.02 is shortness of breath. So those coding procedures, without those, your facility would never get reimbursed for anything that happens. So the CPT and ICD codes, definitely where we're involved, we have to have both of those things in order for us to get reimbursement, financial reimbursement for those exams and studies that are done. All right, back to HIPAA. You will hear HIPAA till you probably are ready to vomit because it is that important. We've already talked about it a little bit, but HIPAA stands for the Health Insurance Portability and Accountability Act. It came out in 1996 is when it was enacted. And we said before that it makes sure that patients have a right to access their personal health information. Excuse me, there is the 21st Century Cures Act, which says that it's mandatory for all health systems, excuse me, to provide patients with notes, reports, images through their portal. So that act says that they have to provide that information to the patient. And then the patient portal, we said, directly allows the patient to have involvement in their own healthcare. Now, the HIPAA Act is a federal act. It's designed to protect the patient's health information, their protected health information. It deals with basically, oh my goodness, I just blanked again. I'm so sorry. Basically, you have to protect that information. You can only share the information about a patient when it's medically necessary or with a provider that has a need or a right to know. Patients can also designate who has access to their information as well. A lot of times they will have to sign waivers or sign paperwork that says you can release results to this person, or sometimes they'll say, no, you can only release the results to me, no one else. So health information privacy is key. It ensures timely access for providers and patients, and it secures electronic health records. Okay, there's two parts to it. There's the privacy rule, which have 8 parts to it, and those are listed on 352 and 353. And then when you see that PHI, that stands for Protected Health Information. And there's 4 parts to the security rule. And those are also listed on page 353. Okay. And it allows for health information exchange, which means that healthcare professionals and patients can access and share medical information electronically, which is huge. Especially, we have a lot of patients that come down from up north, right? The snowbirds. It used to be long time ago when everything was paper charts. If patients were coming down or going back for any amount of time, but they had significant medical things done while they were there, they would have to request copies of all their records and then transport those to the physician that they either were seeing here or back up north, and they would have to be the courier for that information and hope that everything was there that they needed to continue their treatment. Now, with the way we have this information, literally you can grant access, and with a couple clicks of the mouse, those providers can exchange information, or they both can take part in the patient portal and post the information so that each of the other ones is able to see that. So it really has made it a lot easier on patients. It helps to reduce the number of duplicate testing that used to happen quite often. It helps with medications, so that people aren't, issuing medications that counteract maybe when they were down here. There's just so many things that the electronic record and HIPAA and allowing the patient to decide who can access it, it really is a good thing for patients. When they do talk about HIPAA, though, and the electronic health record, recognize that because so many things are electronic, it is very vulnerable to cyber attacks. So cybersecurity is huge. They have to really work to maintain the privacy of those records, because if anything happened, it would be just astronomical and detrimental for the facility. All right. Now, these next 5 slides, I am going to warn you, are not in the book. Okay. So these actually came from a previous edition, and it is still very important and valid information, and I did not want to leave it out. So again, this one and the 4 that follow, there's important information, but it is not in the book. It is only here. And yes, it would be testable because you're hearing lecture on it. So as far as the legal aspect of a health record, okay, health records are considered legal documents. Now, it says the original records are never left in court. That would be if it was a paper copy. But when they have the electronic health records, if it was going to court, they would basically have to print all of that out, or provide some kind of computer to the court system that would allow them to access and see the information that was needed or necessary. A lot of times, though, I feel like they end up printing things out and submitting those to the court. Realize that as a radiographer, you may be required to give a deposition or testimony in a case if it involves any images that were done, if you were involved in maybe the OR case, or your initials were on the images that were taken. You definitely could be deposed or included in testimony. And it is unacceptable for a technologist to provide any examination results. It is outside our scope of practice. Even if it is quite obviously broken, coming through the skin, 2 separate pieces, and the patient can see the image. If they say, or you are not allowed in any way, shape, or form to disclose anything about that. I always joke and I tell you guys that it is outside our scope of practice, but my way around that is to tell patients that they don't pay me enough to diagnose it, and that the radiologist has to earn his keep as well. So you want to refer patients back to their ordering physician, because once those reports are read, the radiologist, those reports go to the physician that's listed that ordered the exam. And possibly there might be multiple doctors, but that's where the results go. So the patient doesn't contact us for the results. The patient would contact whatever physician ordered the exam to begin with. The proper method, if you had to correct an error, now this is in a paper record, okay? You would have to draw one single line through it. You'd have to write the word error, make the correction, and then you would date and sign or initial that correction. Now, when it's in an electronic health record, there is a proper way to do that. it basically is an amendment or an addendum, but it doesn't wipe out the initial information. It's basically got a strike through it, and then the information is updated. So never, whether written or electronic, information is never deleted. It's only, it signals that it was incorrect or erroneous, and then the correction is made. Sometimes patients will talk about the fact that they own their medical records. Okay. Ownership of medical records, basically, if you're going to release any kind of medical information, it has to follow HIPAA guidelines. Any violation of HIPAA can be, or typically is terms for immediate termination with no question. You can't defend it. You can't attempt to explain why. If it truly is a HIPAA violation, you are 99.9% of the time fired, no questions asked. Okay. Medical information, and yes, medication is extremely confidential. The patients do have a right to access their records, and that, when, as far as owning the medical records, typically what I tell you is, like, let's say it's an X-ray. Patients think that they own that X-ray, but in fact, they don't own the X-ray. They own the information that is on that image. But the problem becomes that the equipment that took the image, the technologist that took the image, the electricity that was used, all of that was provided and paid for by someone other than the patient. So the patient does own the information that's on there, but they don't necessarily, well, they don't own the X-ray. That's why they can have access to it. Sometimes there is a fee for that, because someone would then have to, not just the access part, but they might have to provide copies of that image, or they might have to print the report that goes along with that image. So when it comes to this, the patients do have a right to it, but the facility also has a right to charge for it. So we are not allowed to release patient information. We're not allowed to do any of that. If patients want copies of anything or want any of their records, they have to contact that department and sign the appropriate forms, the appropriate legal forms, and give permission to be able to do that. All right, informed consent comes up in later chapters, but it's important since it is part, it kind of goes along with medical records and all the things that you need. Informed consent is required by TJC, and TJC is the Joint Commission. Okay. So the policy, it says, is typically developed by the medical staff and the hospital governing board, and it's consistent with the legal requirements for appropriate informed consent. So what is it? Informed consent basically says that the patient is informed of the procedure or the operation or the exam that is to be performed, any risks that are involved with that, and the possible consequences that can come from it. Okay. So typically informed consent, literally it's implied in the name that you're informing the patient all about the procedure, and then they have to give their consent. The biggest thing with how they do that is that they sign a consent form. The signature is the biggest part of informed consent. Now, is it done on everything we do? No. Typically, it's done when it's some type of invasive procedure. If they're having a needle or a catheter or possibly a barium enema, they could consider that invasive because the enema tip goes into the rectum. If you're having surgery, you would need informed consent. The facility could say they want informed consent on everything. Most of the time, that is not the case, though. So the patient has to be made aware of everything to do with the exam, and then they have to sign the consent form, and it's usually witnessed. So one consent form does not blanket everything they have done. If they had 4 different procedures that were invasive and that's what required informed consent, then we would have 4 different signed informed consent forms. Okay. So it says that when they sign the consent form, the patient or the patient's representative indicates that they've been informed of and consent to the procedure or the treatment. Now, I also said on there, it's not to be confused with implied consent. Implied consent can be one of two things. If something is implied, it means like it kind of goes without saying. So if I have an order for a chest x-ray and I walk in to an imaging facility and I hand them my order and I say, my doctor ordered this, I need to get this done, that's implied consent because I showed up with the order and I'm trying to receive services with that order. So it's implied that I would want that exam carried out or done. That's one thing that can go with implied consent. The other would be in a trauma or life death situation. Most times when there is a trauma and it is life or death, if there is no one there to provide consent for whatever it is to be done and it's truly life or death, most of the time they will proceed with doing the procedure because it's implied that someone would want to survive that event. So you can act on implied consent in that trauma situation too. That's why DNRs are so well, they're important, meaning a DNR is a do not resuscitate order. But just because someone says they have a DNR doesn't mean you go, they code in the x-ray room and you go, oh, they said they have a DNR, so we're not going to do anything. And you let them pass away. In order for that DNR to be upheld, it has to be, it either has to be present or it has to be like on their record, it would say that the patient's a DNR. It would say multiple places that the patient has a DNR, and then you could abide by that. But it can't just be someone saying, oh, I have a DNR, so if anything happens, don't bother saving me. That doesn't work. So implied consent means you either showed up for the exam and it's implied that you're wanting to seek that exam being done, or a life or death situation and without a DNR, it's implied that most patients would want to survive. All right. Some of these last terms that we should be aware of, real quickly, I took out a lot of them that they had listed, but EHR is an electronic health record. EMR is an electronic medical record. HIS and RIS and PACS typically have to do, we see those a lot more, I feel like. HIS is Health Information Systems, and that is what manages all the healthcare data. RIS is specific to radiology. It contains relevant radiology information system. So for all of our services, that's what manages our orders, our scheduling, the billing, and it's a way for us to manage and track patients and also report. They talk about that the RIS typically communicates with PACS, which stands for the Picture Archiving and Communication System. And that is the system that manages all the digital images. That's how our images are stored, okay? And it's typically cloud-based because of the amount of storage that's required for all of our imaging. So one facility would have a PACS system. It's probably backed up multiple times a day, and all those images are stored in the cloud. They reference that the connection between the RIS and the PACS allows for just unbelievable efficiency and ease of access to images, way better than it used to be when you had to send someone to the warehouse to pull images and you kind of hope to God that they were there and they were able to find them and get them back, especially like when surgery was coming or something like that. The last two, AI and ML. AI is artificial intelligence. ML is machine learning. And they talk about that is those two things. I mean, everybody, I feel like, has probably heard of AI, but those technologies help solve problems. and they're designed to imitate our thinking, but they do it much, much faster. Okay. Now, there probably is a lot of controversy about AI, but usually most people don't realize that we already have AI in radiology. We've had it for quite a while. They talk about it. It basically is involved in the algorithms, the equations. Um, they reference in the book on page 354 that those AI algorithms provide ways to highlight the pulmonary emboli on a contrast enhanced CT exam. It can identify kidney cancer. It can do image reconstruction. they've been AI has been around for a long time in radiology. It's just not in radiology. It has. It's just not the way we tend to think about it when we think about typical AI and all the downside to that. Or I guess you could decide if it's downside or not. But typically with AI, it reduces human error. It allows for more precise diagnoses, and it it basically provides a lot of times it's just a tool that's used in order to assist the healthcare providers. When I'm speaking, I'm thinking of the radiologist. It can identify things and kind of flag it so that the radiologist can take a more in-depth look and then decide yes or no. Maybe the AI picked up on something that their human eye did not. Maybe both of them picked up on it. But if it was a case where AI picked up on it and the radiologist did not, but it flagged it so that they could go back, that would be huge and beneficial for the patient. So those are some terms that are worth knowing from this chapter. In conclusion, you can read these bulleted points of how important. I know this chapter isn't the most exciting, but it's definitely important. And without a medical record or electronic health record, we really could not do our job. And we definitely would not be able to do our job as efficiently as we are able to with the electronic record. So if you have any questions, comments, concerns, or complaints on chapter 25, I am happy to answer those once we are back in class. Thank you so much.